I'm very happy for the opportunity to present elements of our book chapter on treating reflux, an aggravating factor in esophagitis. It was published in Esophagitis Recent Updates by Intake Open earlier this year. When stomach acids reflux, they make the condition of esophagitis worse, and it is thus important to understand what reflux is and how it can be successfully treated. I'm working with a gastroenterologist, surgeon colleague at Linköping University to offer this book chapter. GERD and IED are common in the otherwise fit population. Oh, no, excuse me. Oh, yeah. Let me see. Here it is. Excuse me. GERD and IED are common in the otherwise fit population with a prevalence of 10 to 20% in the Western world, 400 million people. Many others with co-conditions also suffer from reflux, making the total far higher. PPI medication is the usual prescription despite known harmful side effects such as osteoporosis, dementia, and cardiovascular diseases. Untreated reflux of acids can also cause esophageal cancer. PPI medication does not address the underlying cause of the reflux. GERD and IgD are just two of the sicknesses caused by acid reflux. This slide shows others too. All are caused by incompetence in the diaphragm, resulting in poor pressure in the hiatal canal and gives these subjects very wide relevance. In the beginning, IED sufferers can drink water, but have difficulty in swallowing solid dry food. Later, liquids can be difficult too. The LES intrudes naturally through the diaphragm when necessary to allow burping or vomiting, but when it intrudes in an unwanted fashion, it allows reflux. A weakened diaphragm can't maintain the required pressure around the hiatal canal. The neck of the stomach and the LES slide up to the and intrude, and the slack esophagus also prevents the UES from opening properly. The UES here. This is IQORA, an innovative evidence-based neuromuscular treatment. It is equally effective in treating dysphagia and hiatal hernia, the cause of reflux diseases. It is a simple handheld training device used to treat dysfunction in the swallowing chain. And in this animation, you can see how it is used.
Exercising with IQORA. Here's how you train. Place the IQORA inside your lips and in front of your teeth. Press your lips together tightly as you pull forwards firmly. Hold still for 5 to 10 seconds. Repeat this 3 times and rest for 3 seconds in between. Exercise 3 times per day and with at least 2 hours between each session, preferably immediately before meal times. In total, 1.5 minutes training per day. Exercising with.
In this X-ray, you can see the internal effect of the training action that we just saw. In essence, the training action stimulates all the organs from the lips to the diaphragm into making a perfect swallowing. I start the video now. You put the IQORA inside the lips in front of the teeth, and you can see what happens. The training is making a perfect swallow. Now, it is not a direct mechanical muscular effect that it's most important, but rather the neurological effect. The lips are the first and fastest key to the swallowing centers in the brainstem. The vellum is the second key. Yeah? Here are the 4 sensory efferent cranial nerves that are triggered when training. They are provoked to send intense stimuli to the cortex and to the brainstem, and this in turn triggers a sensory motor reflex arc, sending commands to the muscles through the 6 motor nerves. So the sensory motor reflex arc is important. The signals from the second level here of the swallowing center stimulate the striated muscles in the oropharyngeal area, the upper third of the esophagus, and the diaphragm. The third level command the smooth muscles in the lower third of the esophagus. The smooth muscles can only be exercised by stimulating the autonomic system to flex them. Earlier studies show that neuromuscular training with an IQR device exercises the entire pharyngeal sling and UES and also the diaphragm. It was hypothesized that IQR training would also make the hiatal canal more competent and thereby prevent a sliding hernia and gastroesophageal reflux. The aim of the following 3 studies was therefore to focus on whether IQR training would improve esophageal dysphagia and reflux symptoms. The effectiveness of IQR has been studied and proven in 17 peer-reviewed, internationally published studies. I shall now present a short overview of 3 of these, which are specifically pertinent to reflux and hiatal hernia. Please note that links are provided to the full publications. In the first study, we recruited 43 patients with non-stenotic IED and GERD for 1 to 15 years. All were on PPI medication for more than 1 year, but still suffering reflux symptoms. Hiatal hernia had been confirmed in 21 of these by radiologic examination, but not in the other 22. Testing was carried out at baseline and after 6 to 8 months training. A variety of tests are shown here, was employed on all patients. In addition, 12 of these patients underwent high resolution manometric examination to measure pressure recordings during IQR retraction. All patients underwent orofacial sensor and motor testing, which ruled out central nervous causes in all cases. At baseline, 100% of patients had pathological values of IED and 86 exhibited reflux symptoms. At the end of training, 98% of IED patients had improved significantly, and reflux symptoms had improved 100% of all patients. 58% reporting being entirely symptom-free. All PPI medications ceased at the baseline, ruling out medication as the cause of the improvements. Swallowing, pharyngeal sling force, and volume closure tests also improved. In all outcome measurements, the improvements showed a 3-star significance. Mean pressure in the hiatus canal increased from 0 to 65 millimeter of mercury, and in the UES from 68 to 95 in those tested. There were no significant differences in test values at baseline or in improvements after training between those with or without a confirmed hiatal hernia, suggesting that the underlying cause of the symptoms was the same in all cases. In the second study, 28 patients with confirmed hiatus hernia and reflux and other symptoms for a median length of 4 years and up to 28 years were recruited. The results were that 100% showed reflux symptoms improvement and 61% were completely symptom-free at the end of training. Again, all PPI medications ceased at baseline, ruling this out as the cause of the improvements. All other symptoms improved too, with a 3-star statistical significance. Traction during the training action with IQORA resulted in a 65 millimeter mercury increase in the mean pressure of the diaphragm hiatus and measured by high resolution manometry. In the first study, 86 patients with verified hiatus hernia and GERD symptoms for between 1 to 75 years were grouped by body type. 3 groups were formed according to body mass index: normal, moderately obese, and severely obese. A widely held options in that obese patients must lose weight before hiatus hernia treatment can be productive. The results showed this opinion to be false. At baseline, there was no significant difference in swallowing ability or IED or GERD symptom severity across the 3 groups, although heartburn, cough, and misdirected swallowing were less prevalent in the normal group. At the end of treatment, IED and GERD symptoms scores were significantly improved. These self-assessed symptom improvements did not vary significantly across the BMI groups. However, symptoms of heartburn, cough, and misdirected swallowing were more improved in the overweight patients. The median BMI did not change during the treatment, hence weight loss was not a factor in achieving the successful outcomes. A further score of evidence of IQORA effectiveness also neatly points out the phenomenon of hiatus hernia often being undiagnosed. In a customer survey made earlier this year, 4,440 people that had started training with IQORA in the last 15 months were asked these questions. 4,304 responded. All these people were treating reflux symptoms, but only 38% had a confirmed hiatal hernia. Gastroscopy is often used when a doctor suspects a more sinister cause like cancer. This examination cannot judge muscle strength. And it can be difficult to diagnose because of its sliding, intermittent nature. Now, it is not possible for us to examine these people and confirm their condition, but we can suppose that if they choose to reduce their medication, they did so because their symptoms had reduced. The same group was also asked whether they had ceased or reduced the intake of medication, both over-the-counter drugs and prescription drugs. Of the 2,462 respondents who used OTC meds, 21% ceased completely, and 54% reduced their medication, totally 75%. Most of those that had not reduced their OTCs had trained with IQORO for a very short time. Of the 2,260 respondents who used PPI meds, 26% ceased completely and 38% reduced their medication, totally 64%. These meds reduction statistics both include those with too short training time to expect a positive outcome, but they are valid for comparison. If now we map this medication reduction against the reported existence of hiatus hernia, we see that there was in fact greater propensity to reduce medication in those without confirmed hiatus hernia. 71% visa 63% in OTC meds and 75% visa 65% in PPI meds. There is a straight line conclusion that says that medication reduction is proportional to symptom reduction. And since IQORO can only treat the underlying muscular cause or the symptoms, the hiatus hernia, then this was indeed a condition present and successfully treated. All studies showed IQORO effectiveness in reducing the incidence of IED, GERD, reflux symptoms, and swallowing compensity. This reduction, the aggravating factor on esophagitis. In all cases, PPI medication was ceased at baseline, supporting the conclusion that IQORO was the cause of the improvements. Reducing body weight was not effective either in the study that measured it. Symptoms and results were the same in the group without a confirmed hiatal hernia as for those confirmed. This suggests that earlier studies that show that 95% of all reflux cases are caused by a hiatal hernia are correct. The large respondent group in the IQORO customer user study support the same contention. But a very large majority of all these users were suffering from a hiatus hernia. The conclusion is that reflux is allowed by the anatomical dysfunction that is a hiatus hernia, and that IQORO is effective at treating this. So, if the symptoms of reflux exist, then it is hiatus hernia, and immediate intervention with IQORO is more important than internal examination to confirm this condition.